Good morning, everybody. Today's date is Friday, March 6th, 2020. It's about 7:30 a.m. on the U.S. East Coast. I am your host, Tom Kaczynski. Welcome to Coronavirus Central. Good to have you here today. Always talking about the disease that is consuming our lives, is it not? And I want to thank, before we get into this, I want to thank the research team on our open source intelligence network at Telegram. That's t.me/coronavirus central. We now have dedicated subgroups for preparedness as well as medical research because we're looking at the papers, we're putting a lot of eyes on things and trying to get information out to the public much faster. I give all the credit to them for that, and they are kind enough to give it to me, which allows me to focus some energy on putting the information out to you as well as my own research. This started out as a one-man band in a lot of ways, and now we're well up to over 1,000 people. I want to thank our 20,000 listeners who are there every day. I know you have a lot of choices now for information on coronavirus, and I'm going to continue to try to do the best I can to put out the stories you need to know, the news that's relevant for you, for the protection advice that's helpful, the studies that show where this disease is going, and as always, to try to anticipate rather than react to it. You know, we are in a war for our lives, and I think that it's really important we remember that. And I want to say also thank you to all the people who've been writing very nice reviews and who have been very helpful. Very much appreciated. Both me and my wife have been working incredibly hard on this, and I know we find ourselves as strange bedfellows in a lot of ways. It's not lost on me that 3 months ago, a lot of us who are listening to this podcast wouldn't have associated with one another for a lot of different reasons. We're from different countries, different backgrounds, different ideologies. And the thing that's interesting is, the economics of it. They talk about the economics, and you talk about the Fed, and you talk about the Dow, which went down another 900 points. But economics is understood much more simply as this. It's scarcity applied, that something is valuable because you need it and you can't get it. And, we lived in a world up until relatively recently of great abundance, where a lot of the fights that were happening were over the question of who would control what resources, and that in correspondence with that, we would fight over those issues because we didn't have a common threat, and we did have a certain amount of standards we were fighting over, and those things did seem very important to all of us, myself very much included, as those who've researched my history know. Yet we are in a different fight now, where we are now allies to one another, where the situation has changed and we face a common enemy in COVID-19 that is a threat to us all. And for that reason, people ask how and why I was able to transition what I was doing so quickly from a seemingly different background. Well, the truth is, I've always been someone who fights for what I believe in, and who fight for people who will fight alongside me. And one of the great things, and the only great thing of this whole horrible experience, has been the understanding that when we face a common enemy, that there is something that unites us and our better spirits as people. And that I am grateful for that, and for the many kind people who are a member of the Coronavirus Central family that have been working for this, and whom I would fight for, die for, and will work with until the very end, which will be when we overcome this terrible disease. So I wanted to put that out there and just remind you that point about economics is scarcity, because as we go forward with this analysis, what we're going to find is we're going to transition as time goes by, inevitably, as we gain better understanding of this disease and what it purports for us. Obviously, we'll talk about protection, we'll talk about outbreak, we'll talk about how we handle this, but the decisions that have been made by the governments of the world to this point are such that it is likely that this will be widespread, contagious, and endemic throughout large portions of the world. And at this point, I don't have anywhere I would specifically exclude from that. That being the case, then we have to learn to live in a world where COVID is a reality. What can we do to mitigate it? Ideally, what can we do to remove it? What does it mean for our economic system, our political system? And what do we need to do in orienting ourselves, as this show has argued from day one, to protect the public health? And that means we're going to have to think about things very differently. Today, we're going to get into that a little bit. We got some good stories about what's been going on over in China, some more case numbers which talk and will be useful in understanding the spread and giving a little more detail about how children may be carriers even though they are not necessarily being harmed themselves. I think it's really important as we understand how this spreads and what policy decisions to make, that we look at that. And I know a number of places, a number of countries, and some individual school districts in the United States are looking to keep their kids at home. And I know that a number of our listeners have been concerned about that. So we'll look at it from a study perspective. We'll look at a study about the transmissibility through fecal matter. It looks like it's better for, testing purposes than necessarily being the most dangerous route of spread, although it certainly can happen. We're going to take a little bit of a deeper dive today into what's happening with the bill coming out of the U.S. Congress, what that means, and what they're providing resources for. I'm glad to see they're moving forward. This is a start, not an end. There's a lot going on there. We're going to talk about the UK response. We have a lot of listeners in the United Kingdom. Thank you to you guys across the pond. I've been trying to offer my best analysis of what's happening over there for your unique situation. And honestly, there's a little bit more transparency in the British response than there is in the American response. So we can probably extrapolate for that audience and other audiences, of course, around the world, as we are in. I think we're in slightly more countries right now than the coronavirus is, but it's a race, and ultimately I think they're going to win. But let's hope not. And then at the end of this, I have a little bit of an interesting story. It's highly speculative, but we'll put it out there about some preparations that might be happening underneath our nose. A lot of conversation, chatter about there about quarantine sites, military movements. I don't have anything specific to give you. If I do, I'll put it out there. I think the government has to be looking at these things. But ultimately, the limits of what they can do and creating more problems as opposed to assets is going to be an issue. So let's get into it, as we always do, with COVID-19info.live. And just as a reminder, all old episodes are available at coronaviruscentral.net. If you're looking for the notes for the different articles that are referenced herein, I put them all in there, so you have links. You can review these for yourself. Definitely want you to be able to do that. Episodes will be simulcast on YouTube, and this is available if your platform brings it down as of right now on iTunes, Google Podcasts, and Spotify, and it will always be available on coronaviruscentral.net. And if they take that down, we will be on Telegram. And if they take that down, you probably have bigger things to worry about. So let's hope they don't take that down. Okay. COVID-19info.live, last update. This is as of 7:20. See what a little F5 action does if that updates it. 7:30. Okay, we do have an update. So as of right now, we are at 99,971 cases. So I guess we're going to crack that psychological barrier of 100,000. Odometer effect is a real thing. A lot more people will be paying attention. And if you are new to Coronavirus Central, there's a lot of sources out there. The other sources will tell you what the media is reporting, and we've been ahead of the curve. You can listen to any of our members, lots of reviews on that. We have been looking farther, deeper, harder, and trying to anticipate what is happening with this, and hopefully we continue. The death rate remains at 3.4% observed today at 3,400 cases, and the recovered rate is listed at 55,644 at 55.7. And I don't mention the recovered rate often because we talk on this show, there's a lot of questions about what cured means. We have instances that we've reported on this show in at least 5 countries of people who were reported cured who then either A, got sick, or B, died. Nonetheless, I mention it only to give people who are listening a little bit of hope and the understanding that even in the worst case scenario, what our observations have been thus far is that 80% of the people who do get coronavirus or higher potentially end up having only mild, moderate symptoms, somewhat like the flu, and that they do end up surviving. Are there long-term consequences, including some of the neurological symptoms that we are at the cutting edge of exploring? Perhaps. We're very concerned about that, but you worry about the enemy in front of you today versus tomorrow. The world will go on, and I have confidence in that. So let's continue onward and look at those. And a lot of those numbers, to be very clear, are coming out of China, where they claim they have 67% of the cases cured. The numbers out of China that are being reported as of right this moment, 80,556 confirmed, 3,042 dead, and for 53,810 recovered. It's a death rate of 3.8%, they're claiming. There's issues with those Chinese numbers. We'll see how they hold up over time. Hopefully they are indicative and that the rate stays that low. We have reasons to believe they may be higher in every element, which, at this point, the best suggestion I can make to people is to assume this is coming to your community unless you can keep it out. And that's going to be what we observe just based on the modeling that everyone seems to sort of agree upon. We'll have a piece from the NHS about that later, but this is going to continue to increase through March and really hit super hard in April. And then we'll see what happens after that. If there's reinfections, we don't really know. I mean, there is a little bit of evidence coming out of China that people are getting sick again as they send them back to work, and that there are limits. I mean, there is some curative measures like chloroquine we've talked about, remdesivir, but we also have to factor that against the fact that people coming back online at a time when supply chains are disrupted. What are the risks? What are the hazards? These are questions that you need to consider. It's why from day one, the position of this podcast has been self-quarantine would be smart. And if we looked like we were a little bit too early, now we're starting to look like we're not late at all. So that's good. Another big jump in South Korea, 6,593 cases, 40 deaths. Iran, 4,747, 124 deaths. That's 2.6. It looks like they're getting a better handle on at least testing some people and figure out who's confirmed, although that death rate is probably really low in Iran, based upon evidence we've had from a lot of different sources, on multiple platforms, honestly, that other people are reporting as well. Italy, 3,858 continues to go forward there, 148 cases. The Europe cluster of Germany at 545, France at 423, and Spain at 282 is advancing. You got 10 deaths between them, 7 in France, 3 in Spain. Japan is moving up steadily. Once again, one of those community spread issues, 360 confirmed, 6 deaths. The United States making another big jump up to 233 with 12 deaths. The new announcement that the FDA had changed its protocols where individual states can begin acting to test and do so quickly, I think is going to lead to a continuing rise. The U.S. numbers are going to spike. Be prepared for this number to be into the thousands by next week. It's sort of inevitable at this point. And the biggest choke point on that is the number of tests. So Switzerland is making a big jump to 119. Singapore holding steady at 117. The UK is at 116. We reported yesterday that there was a lot of controversy about the idea that they're only releasing the statistics once per week now, so that they can provide it differently. A lot of people are going to be very unhappy about that. And honestly, I don't think they're doing themselves any favors, because that number is going to jump in a big way. If they report it on Fridays, they'd be better off spacing it out, but they have 1 death over there. Hong Kong's at 107, and we'll just go through a couple other ones here, just to give you a feel for what's happening around the world. Sweden, 94, Norway, 91, Netherlands, 82, Australia, 61, Kuwait, 58, Bahrain, 55, Malaysia, 55, Belgium, 50. And what you see is these case numbers are doubling about every 3 to 5 days. Pick your country, but that's about what we're looking at. And that's been close to the predictive model I've been arguing. I've said 4 days as sometimes or twice per week, just to make the math a little easier. But I suspect we'll continue to see that. And here's the thing. Absent any quarantine measures, and absent reaching a saturation point where the curve will level off because everyone's sick, the expansion phase of this disease is going to be such where for at least the next few weeks, I think we should expect to see that sort of doubling happen unless there are very effective quarantine measures put into play. And regardless of what governments are telling you about case counts in your country, your state, or anywhere else, what you have to expect is that the pattern we've seen before will be indicative of what we would expect for the future. Some of this can be mitigated by social distancing, people wearing masks, people, washing their hands. But the reality is you represent a very awake audience if you're listening to Coronavirus Central that very many people aren't listening to at this point. And unfortunately, a large part of that responsibility has to exist within the government and different governments for downplaying the severity of this outbreak, including that we continue to hear things from our president that underestimate the import of this, and I think it's an incredibly reckless and dangerous act that he's been doing. And I don't say this from a position of being an ideologue. I am going to just say when people do things that are helpful to the spread of this disease or hurtful to the spread of this disease, I'm going to call it how I see it. And I have to be able to comment on policy I'm not inserting any ideological component into that other than to make the point that it's very important that we look at who is addressing the problems in front of us with the hope that everyone is successful in a bipartisan transpartisan and international manner, because we're all fighting the same enemy. When one group, you don't, if you're in one army, you don't want your flank to collapse, you know what I mean? So we're going to go into an article here. This is, I got this from MedRxiv, and this was shared with me. Let's see, the primary authors, this is a collaboration between the members of the Johns Hopkins Bloomberg School of Public Health, the Shenzhen Center for Disease Control, the Pengcheng Laboratory, and that is it. And there's literally a stack of authors that's pretty long on this, so we're going to leave that for the moment. But it's the epidemiology and transmission of COVID-19 in Shenzhen, China, an analysis of 391 cases and 1,286 of their close contacts. This is a preprint, so preprint has not been peer reviewed, so it will be peer reviewed. So they say don't use it to guide clinical practice, but these things go through, and they're pretty. These are reputable sources. This will be reviewed, and people will have opinions, and we'll discuss them as they come out. That's what we do. But we're putting these out because this is the cutting edge of it. So what this article really goes into is they looked at a whole bunch of cases in southern China, and they were trying to figure out, from looking at them, what were the means by which this was being spread so that they could reduce that R0 rate, that transmission rate. And we'll go into a sort of broad discussion of it. It's a 21-page paper. I'm not going to subject you to that. I will read the abstract and some conclusions, and we will have a link up to this on coronaviruscentral.net. And if you want to have more discussion about it, t.me/CV Central Research. We have people looking at this and other papers as they come out in real time. So, here's your abstract. Background. Rapid spread of SARS-CoV-2, that's COVID, in Wuhan prompted heightened surveillance in Shenzhen and elsewhere in China. The resulting data would provide a rare opportunity to measure key metrics of disease control, transmission, and the impact of control. So what they're saying is China basically locked things down, and that they could see what was happening in real time because they had the ability to have that level of surveillance. And as such, they may have a more effective predictive model of what happened and how the disease was spreading. Now, there are problems in this, in that you have to trust what's being said, that there are going to be issues with the surveillance in and of itself, and also that we should not assume that A, this is the same strain, or B, that this will behave the same in the same environments. Nonetheless, this is the research we have, and it does provide some more data points that should have at least some validity for what we're looking at in the Western world and in other scenarios. So let's go into it and see how it fits what we're observing here on the ground. And if it ends up being radically different, then that might suggest that we need to look more closely at the disease or some failure of the policy response. All right, methods. The Shenzhen CDC identified 391 SARS-CoV-2 cases from January 14th to February 12th, 2020, and 1,286 close contacts. That's saying who did you talk to, how could you have got them sick, and figuring out how the vectors of disease spread happened. We compare cases identified through symptomatic surveillance and contact tracing, and estimate the time from symptom onset to confirmation, isolation, and hospitalization. We estimate metrics of disease transmission and analyze factors influencing transmission risk. Findings. Cases were older than the general population, with a mean age of 45 and balanced between males, 187, and females, 204. 91% had mild or moderate clinical severity at initial assessment. 3 have died, 225 have recovered, with a median time to recovery of 32 days. That number, I think, is going to be really important. Keep that in mind, that if we need to have people who are using hospital resources, there's a metric that's used in the industry called bed days, the number of days in which a patient is occupying a bed. You're going to hear that more in the future, so I'm putting that out there, that it's not just how many people get sick, but how long they need help for. Cases were isolated on average 4.6 days after developing symptoms. Contact tracing reduced this by 1.9 days. So they were saying they were able to find people a third faster by tracing who had what, and obviously that will get difficult as the numbers get higher. Household contacts and those traveling with a case were at higher risk of infection with R0s of 6 and 7. Well, it says ORs 6 and 7. I wonder if they've reversed that there. I'll have to look. Then other close contact. The household secondary attack rate was 15%, and children were as likely to be as infected as adults. That's a really important point there, because we've been looking at this as a disease that doesn't affect children, but what might be more accurate is it is a disease that lightly infects children, where they aren't aware, or it doesn't rise to the level of them, needing medical intervention, which is good, but it's also bad because it means that schools become a carrier system. And if, as we know from the flu and other diseases, infectious diseases, that when school season starts, that's when the flu starts moving around, because children do these things. And I think it's reasonable to consider that coronavirus may be spreading through the same action. And what that means in terms of public policy is that if we wanted to arrest the quickness and the rapidity of the spread of the coronavirus, you're going to see school districts shutting down. And we've already seen that, actually, of school districts in California and Washington that I'm aware of, near the breakout areas in Santa Clara County and King County, Washington. Okay, let's see where we were here. The observed reproductive number was 0.4 with a mean serial number of 6.3 days. So what they're saying is that they got in there, that they got the number down under 1, which is what you would have to do to stop the outbreak, and that's what China claims to have accomplished, and that they're going in there and they're literally tracing every person in their society. That's something you can do in China. I don't know how possible, effective, pragmatic that is in the West. It's a conversation we're going to have a lot more discourse about going forward, just because we here in the West would have other issues because our expectations are so different, and some of those are things we have to push aside, and some of them are going to be a lot more challenging that we need to honestly consider. Anyways, continuing. Interpretation. Our data on cases and their infected and uninfected close contacts provide key insights into SARS-CoV-2 epidemiology. This work shows that heightened surveillance and isolation, particularly contact tracing, reduces the time cases are infectious in the community, thereby reducing the R-naught. Its overall impact, however, is uncertain and highly dependent on the number of asymptomatic cases. We further show that children are at similar risk of infection as the general population, though less likely are to have severe symptoms, hence should be considered in analyses of transmission and control. And let's just keep in mind that observed reproductive number doesn't mean the whole society. That's just meaning contact tracing allowed them to get those cases down to a level where they were taken off the table, rather than the idea that the whole thing was taken care of. So I'm going to pick out highlights from this just to try to make this make more sense here. And this is from the results section, epidemiological and clinical characteristics. Just want you to know what they were observing, because I think it might be helpful for maybe what we see here. It's a little different than some of the other studies, so it's interesting to me. Between January 14th and February 12th, the Shenzhen CDC confirmed 391 cases of SARS-CoV-2 infection. Of 379 with a known mode of detection, 77 were detected through symptom-based surveillance. Overall, and that's as opposed to, I assume, contact tracing. Overall, there were approximately equal numbers of male and female cases, 187 versus 204. 79% were adults between the ages of 30 and 69. At the time of first clinical assessment, most cases were either mild, 26%, moderate, 65%, and only 9% were severe. 84% of cases had fever at the time of initial assessment, while 6% had no signs or symptom. As of February 22nd, final clinical outcomes were known for 228 of the 391 cases in our data, with 3 having died and 225 having recovered. Cases detected through symptom-based surveillance were more often male, 55% versus 28%, and between the ages of 20 and 69, 91 versus 75%. Than those detected through contact-based surveillance. I just want to mention that point about the male thing. It seems like there's been recurring evidence that men are hit harder by this for whatever reason. Perhaps has to do with the number of ACE2 receptors that we've talked about, and that's one of the things that we know the coronavirus targets for entry into the system. A lot of research about that. And if you want to understand better how this works, please check that out. So you'll want to look up the angiotensin converting enzymes. Okay. At the time of the first clinical assessment, 29% of the contact-based surveillance group did not have fever, and 20% had no symptoms. And this kind of shows the limits of what's happening with the quarantine efforts worldwide, where if you're letting 1 in 5 people who are sick through, it ain't going to work. And that's what's happening. In contrast, 88% of the symptom-based surveillance group had fever, and only 8% reported no symptoms. I'm going to just pick some of the pieces out of the discussion, right, because I think this is important too. This work further supports the picture of COVID-19 as a disease with a fairly short incubation period, a mean of 4 to 6 days, but a long clinical course, with patients taking many weeks to die or recover. It should be noted, however, that we estimate a higher proportion of cases taking 14 days or more to develop symptoms at 9% in previous studies. And that fits the data that we've seen where we've reported and stories we've read about 21, 24, there's even an outlier with 42 days. So if 10% of the people are having these really long infection times, what it would seem to suggest to the epidemiology is that with coronavirus, you end up with a whole bunch of things attacking very short term and some of these long-term things that take longer to manifest. Why that should happen in different people is an interesting question. Is it something that has to do with the nature of the immune system, the infection, and how this gets into our system? I don't know, but I think those are important questions to look not just at the people who are getting this disease, but the people who are surviving it, and to give them a full battery of tests so that we understand what the actual situation is. You know, we've talked about, is this a situation where they're in remission? Is this something where it is migrated to some sort of a chronic condition? Like we could see with HIV. We don't know that. I think those are important questions. So I want to say, here they say, in Shenzhen, SARS-CoV-2 transmission is most likely between very close contacts, such as individuals sharing a household. However, even in this group, less than 1 in 6 contacts were infected, and overall we observed far less than 1 onward transmission per primary case. As noted, low transmission levels may be in part due to the impact of isolation and surveillance, but it is equally likely unobserved transmission is playing some role. We also estimate reasonably high rates of over-dispersion in the number of cases each individual causes, leaving open the possibility that large COVID-19 clusters occur even when isolation and surveillance are forcing the R0 below 1, events that could potentially overwhelm the surveillance system. So they're saying here that they don't really know why it is that it would seem on the surface of it that in isolation people don't get each other sick, but that there is transmission happening through other means and that we don't understand all the vectors of this. Could it be the aerosolization? Could it be that there's some third entity that's spreading this? I read one thing, it was highly speculative, it said maybe it's carrying on a bacteria that we're not looking for. We don't really know, but it's interesting because we have a big R0 and we are seeing the limits of isolation in stopping this. And they're very clear about this. I'll just read the last 2 paragraphs. This work has numerous limitations. As in any active outbreak response, the data were collected by multiple teams under protocol that, by necessity, changed as the situation developed. Hence, there may be noise and inconsistency in definitions. Of note, the definition of a confirmed case changed to require symptoms near the end of our analysis period. But sensitivity analyses show that truncating the data at this point does not qualitatively impact results. It is, likewise, impossible to identify every potential contact an individual has, so contact tracing focuses on those close contacts most likely to be infected. Hence, our observed R0 is assuredly less than the true R0 in the population. As asymptomatic travelers will be missed by symptom-based surveillance, and even if tested, some asymptomatic contacts may be missed due to the imperfect sensitivity of the PCR test. And that testing has been a real problem. As we get new forms of testing online, the Singapore test, for instance, that we talked about that involved swab yesterday, I think that's really going to potentially help deeply. And I just wanted to, just a real quick insertion because I didn't mean to forget it. The other day I misidentified what an SNP was. It's a single nucleotide polymorphism, and it's the most common types of genetic variation amongst people. So usually they're kind enough to put these things in here, but a couple people called me on it, and I want to thank you for letting me know. And I will definitely remember that in the future. So a lot of times there's a lot of word soup in this, so I apologize. I mean, for specialists, I'm sure it's frustrating, but I'm learning as fast as I can as a lay reader. So let's continue. As SARS-CoV-19 continues to spread, it is important we continue to expand our knowledge about its transmission and natural history. Data from the early phase of local outbreaks, when detailed contact tracing is possible and sources of infection can still be reliably inferred, are particularly powerful for estimating critical values. This is especially true when information on uninfected contacts and mode of detection are used. As we have done here, the resulting estimates provide critical inputs for interpreting surveillance data, evaluating interventions, and setting public health policy. So if you read the thing in more detail, it just talks about how they discovered these things. But the big takeaway, and the reason I shared this article with you, was one, to give you a little more information about what they were finding in China, where they have large case numbers. And in this case, the numbers seem to be a little bit less severe, with the number of people who are experiencing severe cases down to maybe 10%. That would be really good news. And obviously, I think their isolation and quarantine measures are having a big role, and there's a lot we can learn from that. However, the bigger takeaway that I wanted to add to this that I think is important is that they do mention several times in here that we are looking now at a situation where there are a number of means of transmission outside the family that need to be considered. That's the first thing. And secondly, we know that children are getting infected at the same rate. I've had a lot of mothers especially reach out to me about that and their concerns for their children's welfare. So the good news continues to be that we see a very low observed rate of anything beyond mild symptoms with children, as this study substantiates. And the bad news is your kids are getting everyone else sick as this is spreading, and that would make a lot of sense that it would happen that way, because a lot of diseases spread that way, especially infectious viruses. So it's something we're going to have to keep a close eye on, and then, the question of what this means for longer-term implications. I keep bringing that up there because I don't want people to overlook that, and I know I might be beating a dead horse, but it's something that really worries me, and I suspect strongly, and call it an intuition, but the data seems to suggest this, that we don't really understand what the long-term impacts of this are. And we've talked about this idea that, a lot of different elements exist in the coronavirus. And until we know what they are, I'm just taking the position of maximal security. And who knows, maybe I'll speculate about it tonight. And also a reminder, I do a show usually Monday, Wednesday, and Friday. I wasn't available on Wednesday, but I will do a show on Friday on YouTube at 7 p.m., check out Coronavirus Cast on Twitter. I always put the link up there because I have to put it up right before it comes on. If you want to talk, here's some things, put your ideas out there. It's much more free form. We speculate, we go where the conversation goes. Usually I go for an hour, sometimes an hour and a half. And if it does cut out, by the way, because I have a weird problem with YouTube, I don't know what's causing that, just wait a second. We'll post a link to where it relaunches. So a real brief mention of this article. I'm not going to read the whole thing, but it's from the Journal of Medical Virology from Jin-Cheng Shang. This is it's an accepted article. I think it still needs to be peer-reviewed. But fecal specimen diagnosis 2019 novel coronavirus infected pneumonia. And we'll just read the abstract of it. I'm not going to read the whole thing, but it might prove useful as we look for diagnostics. The emergence and spread of 2019 novel coronavirus infected pneumonia, COVID-19, from Wuhan, China, has spread globally. We extracted the data from 14 patients with laboratory-confirmed COVID-19 from Jinhua Municipal Central Hospital from January 27, 2020. We found that compared to pharyngeal swab specimens, nucleic acid of COVID-19 and fecal specimens was equally accurate. And we found that patients with a positive stool test did not experience gastrointestinal symptoms and had nothing to do with the severity of the lung infection. These results may help to understand the clinical diagnosis and changes of clinical parameters of COVID-19. So there's two things we can take from this, and it's a 7-page article beyond that, so you can read it if you like. But number one is that there is active virus that's in the feces, so that would stand to reason to be a potential vector by which we would see this spread. And just one more point to emphasize the importance of hygiene, good hand washing, social distancing, everything that you should already know. But more importantly, they were able to take tests from stool samples that apparently were just as accurate for these 14 patients, it's admittedly a small sample, as the existing swab specimens that they've been using. And I would say that for the ability, I think most medical facilities do have the ability to take stool samples, and potentially there is an opportunity here to draw upon this study and maybe a opportunity for cooperation and collaboration where we can maybe develop another testing protocol that would be, one, easier to implement, and two, safer for people, so this could be done in a more sterile way, because we don't want to have this ongoing problem of people getting sick who are in the medical profession. And to that end, we'll go to the next story. Now, this was going pretty viral, actually, and this is a story that was shared by both the California Nurses Association and National Nurses United. That seems to be some sort of association between nurses, but it's a story of what's happening on the ground and the failure of our system to provide protective ability for our medical staff, including doctors, nurses, support staff, and also patients. Obviously, part of that's caught up in the lack of PPE. We're going to talk about that in some detail. And I've had a number of nurses reach out to me asking what they can do, what they should do in terms of working for their own protection. And what I would suggest is that we, the public, would support our health professionals if they demand that when their healthcare system service, be it private or public, not provide sufficient care, that they go ahead and make it impossible for them to act without those actions. We do not want the spread of this disease, and obviously we don't want to see anyone not have care, but we have to go ahead and act intelligently and create public pressure. And I would hope that everyone listening to this podcast, in the interest of public health in your home country or state, will do the same thing. So let's read this story, and it's going to be a little upsetting, but I want to share it with you. So this is a statement from a quarantined nurse at a Northern California Kaiser facility. She chose to remain anonymous because she didn't want to lose her job, and we understand that. Okay, March 5th. As a nurse, I'm very concerned that not enough is being done to stop the spread of the coronavirus. I know because I am currently sick and in quarantine after caring for a patient who tested positive. I'm awaiting permission from the federal government to allow for my testing, even after my physician and county health professional ordered it. I volunteered to be on the care team for this patient, who we knew was positive. I did this because I had all the recommended protective gear and training from my employer. I did this assuming that if something happened to me, of course I too would be cared for. Then, what was a small concern after a few days of caring for this patient became my reality. I started getting sick. When employee health told me that my fever and other symptoms fit the criteria for potential coronavirus, I was put on a 14-day self-quarantine. Since the criteria was met, the testing would be done. My doctor ordered the test to the county. The public county officer called me and verified my symptoms and agreed with testing. But the national CDC would not initiate testing. They said they would not test me because if I was wearing the recommended protective equipment, then I would not have the coronavirus. What kind of science-based answer is that? What a ridiculous and uneducated response from the department that is in charge of our health in this country. Later, they called back, and now it's an issue of something called the, quote, identifier number. They claim they prioritize running samples by an illness severity, and there are only so many to give out each day, so I have to wait in line to find out the results. This is not the ticket dispenser at the deli counter. It's a public health emergency. I am a registered nurse, and I need to know if I am positive before going back to caring for patients. I am appalled at the level of bureaucracy that's preventing nurses from getting tested. That is a healthcare decision my doctor and my county health department agree with. Delaying this test puts the whole community at risk. I have the backing of my union. Nurses aren't going to stand by and let this testing delay continue. We are going to stand together to make sure we can protect our patients by being protected ourselves. And I'll tell you what's going to go further from this, and just my interjection here, is that if you can't protect nurses, they're not going to show up. I mean, and why would you? Let's be honest. I mean, it's one thing to ask for people to take risks. It's another thing for people to ask to put their life on the line in a way where they're not even being given adequate protection. And once again, we see our good friends at the CDC manage to fail. And honestly, look, I mean, everyone needs to get tested who wants testing. There's a lot of problems out there with that. I think the people who are talking now about the import of testing the uninsured, that's a very large number in the United States, that needs to be part of the national conversation as well. But the very first people who need to be optimally protected and that we need to get testing for as needed are the medical professionals, because without them, the whole system falls apart. And this is just an example in real time, a data point, if you like, that shows the strain the system's starting to have because we had inadequate preparation. And that's really unfortunate, because they will tell you they had no way of knowing. That's a load of crap. We knew a month ago on this broadcast. They knew in China in January, and I guarantee you the government had information coming out of there that had at least some value and enough to say, hey, let's start thinking about this. What the CDC has been doing has been absolutely abhorrent, and they continue to be such a disappointment through this process, as this woman shares, and I hope they get better. I want them to succeed, but honestly, I think that when this story finally gets told, we're going to find a really disappointing response from the CDC specifically. And this is one of the reasons why we talk about alternative testing, and we applaud the administration by the administration in association with the FDA to take testing away from them, because they've been a bigger part of the problem than the solution. So I want to go to this next story here. I'm just going to read the headline from it because I can't see it all behind the paywall. Thank you, Washington Post. And that's one of the reasons why we're going to have a Kickstarter coming out, actually. And I will share the link for that. It is going to be, if you go on Kickstarter.com and you look up Coronavirus Central, you'll see the pre-launch for this. We're going to ask for your help to go out here, and so I can get more information out there, share more information with you. If you're willing to put in the price of a cup of coffee, we can save many lives. This information does make a difference. I've had many testimonials, well into the dozens. We're nearing 100 now, of people who've taken actions to increase their security in terms of food supply, in terms of protective behaviors, and we're going to continue to do that. I want to do this full time. You want to keep listening, and if you're not willing to throw a quarter my way, I mean, what is it worth to you, right? So kick up a little bit, help out. If we get more money, we're going to do more things, and that's what I can say to you. We have a lot of exciting ideas about how we can draw upon our intelligence network, and really, one of the things we've seen in every country, we've seen this in China, we've seen this in Iran, we see it everywhere, is the quality of information. You want to have oversight where there are public open source networks that are looking at what the government is doing, because we've seen already to this point, whether you think it's because of bad action or incompetence, they have not been able to report the truth. Take our track record against theirs, and hey, if it's something you want to support, do it. Otherwise, we're going to continue going forward. It'll make a difference with how much I'm able to devote to this, and I want to keep doing it, and hopefully you guys want to keep listening. If not, what the hell are you doing listening to this, right? All right, so let's go to the Washington Post article, and I'll put a link up to the Kickstarter so you guys can see that. It's really a good deal. Okay, and it's cheap too. Because and for people who don't have money, man, I mean, it's fine. Believe me, I'm not gonna shoot you for being in that position. I know what it's like. I'm there. Okay, so this is the Washington Post article. It says Washington State asked the U.S. stockpile for coronavirus masks. The response raises concerns. And one of the things we saw was that Washington State authorities sent an urgent request to 233,000 respirators and 200,000 surgical masks. Now, there wasn't a lot of clarity about what they mean by respirators, so we'll have to figure that out a little bit more. But they asked for it to be released from the federal government's strategic national stockpile. And within this article, I am given to understand, even though I haven't read it myself, is that they do not have enough for these continuing actions to happen in all of the various states. That suggests a supply shortfall. We do know that the government is working with respect to the masks with 3M to directly increase that supply. A promise was made by Vice President Pence at the beginning of this week that we would have 1 million masks available. The best evidence out there is that they are not meeting that level yet. Production capacity is coming online, but frankly, I don't know the actual numbers. I know he was having a press conference with Governor Inslee of Washington. We didn't have hard numbers out of there as well, so hopefully they're able to get that going a lot faster, but I do want you to know that we now see states requesting help from the federal government and hoping that that will help. And this is why I want to go to the next thing, which is we're going to read an article here. This is from National Public Radio, NPR.org, and it's going to take a look at the bill that is passing very quickly through the House and Senate. I suspect this will be the first bill, not the last bill, related to the coronavirus. And I'll just read the whole article so that it gives you a feel for what the federal response looks like, both in terms of finance and priority. I, at this point, am going to say yes to everything, but I will, if I offer a critique, it will be to offer areas where I think we can further expand this. I don't think $8 billion is nearly going to be enough. I mean, I honestly think it's going to take... Before this is all done, if we want to be serious about this, it's going to take $1 trillion expenditure, and I'm aware of what a problem that is in every way. But we talked about the study from Australia. We talked about the Society of Critical Care Professionals saying that the current expenditure per year for the amount of ICU support is in the neighborhood of $4 billion. If I remember my numbers right, and we're going to have to increase that at least 100-fold, 400-fold, if we want to be able to cover everyone at once. Obviously, that's not going to be achievable, but as we flatten that line out and look at some of the other issues that are economically going to be caused, this number is going to get huge. And really, it's going to require us to think about economics differently. We can't think about it in terms of finance and dollars and cents. We have to think of it in terms of scarcity. And the scarcity is what we need to stay healthy and staying healthy. The priority has to be people-based economics. And I know that's not something the United States is particularly good at. The good news is we will eventually get there. The bad news is how many people the politicians will sacrifice along the way in unhappy compromises. This bill that they're passing is a first step to hopefully mitigate that. Trump did sign an $8 billion coronavirus response package on Friday. Author is Claudia Grisales, March 4th, 2020, 2:45 Eastern Standard Time. President Trump is expected to sign an $8 billion emergency spending package into law Friday, responding to growing cases linked to the coronavirus domestically and abroad. Visiting Olympia, Washington on Thursday, Vice President Mike Pence praised Congress's bipartisan response and said some of the funds would be available for state and local response. The Senate overwhelmingly passed the package Thursday with a 96-1 vote. Kentucky Republican Senator Rand Paul opposed the bill. He proposed an amendment that offset some of the costs of the legislation with cuts elsewhere, but that effort failed. And look, I mean, I have a lot of libertarian friends. Now is not the time to be saying that, you know, I understand where Senator Paul's coming from. This was not the time for that. Sorry. The action follows a similar bipartisan House vote a day earlier. A bipartisan group of members and staff for the appropriations panels in both the House and Senate unveiled the legislation on Wednesday after several days of talks. They released details of the plan, which will boost funding for testing of the virus and lower costs for federal-related medical treatments. Although partisan disagreements on providing affordable access to treatment slowed down negotiations in recent days, members said putting politics aside finally provided the breakthrough they needed to reach a deal. This should not be about politics. This is about doing our jobs to protect the American people from a potential pandemic, Alabama Republican Senator Richard Shelby, chairman of the Senate Appropriations Committee, said in a statement. We work together to craft an aggressive and comprehensive response that provides the resources the experts say they need to combat this crisis. I thank my colleagues for their cooperation and appreciate President Trump's eagerness to sign this legislation and get the funding out the door without delay. The funding plan is significantly larger than the initial request from Trump to allocate $2.5 billion $2.5 billion to efforts to fight the coronavirus disease. Both Democrats and Republicans said that more was needed to address the growing outbreak, and I thank the Congress for taking that step as a first step, and that we need to go further. Absolutely. As the number of confirmed cases of coronavirus in the United States continues to grow, Congress is taking swift action this week to provide our health experts, hospital healthcare providers, and state and local governments the funding they need. Senate Minority Leader Chuck Schumer said on the Senate floor ahead of the deal announcement. The Senate Appropriations Committee summary of the funding plan indicates that 85% of it will go to address coronavirus concerns domestically. This money is designated for coronavirus prevention, preparation, and response efforts, the panel said. And that number might sound low a little bit because you'd want it all to be devoted here. But what they're doing, I've read the bill, is that they're putting some money into the State Department to do screening offshore to prevent people from coming here, as well as preventing certain critical networks that would likely infect us, given, migration patterns in there. It's not, that 15% is not poorly spent, let's put it that way, at least the parts I could see. The plan includes almost $7.8 billion in new funding to combat the spread of the virus at local, state, and national and international levels, according to details from the panel. The agreement also includes a provision to allow Medicare beneficiaries to access telehealth programs that will let them remotely see providers to assess symptoms potentially tied to the coronavirus. And I think this is actually a really good start of something that's going to have to get bigger. I just want to draw this point out, that if we can prevent people from having to go to doctors, especially people who have ongoing existing chronic conditions, who are a high at-risk population, but B, many times dependent on the public health care system, who have to go because of various statutory guidelines. I think if we can waive them for the duration of this crisis and then have them get on the computer and meet with their doctors, I understand that for certain diagnostic actors, that's not a viable action. However, I think for others who are basically going in for mandated checkups according to different health insurance regulations, we can potentially remove an at-risk community from threats. If that's expanded, I hope they look at that. And I hope medical systems actually look at that too and begin pushing. There have been a number of people involved with hospital systems that have taken some of the suggestions in this show and begun implementing them. So hopefully that's something we can do to increase the protection for everyone involved. Okay, to protect public health, the bill will allow Medicare providers to extend telemedicine services to seniors regardless of where they live at an estimated cost of $500 million, House Speaker Nancy Pelosi said in a written statement. The bill also allocates more than $300 million to ensure when a vaccine is developed, which some estimate could be a year or more away, and I think that's a reasonable estimate, that Americans will be able to access it regardless of their ability to pay, according to a congressional aide involved in negotiations. And that has to be the case, otherwise, that just has to be the case. And it should be. Overall, the plan allocates nearly $6.5 billion to the Department of Health and Human Services, which includes $2.2 billion for the Centers for Disease Control and Prevention to address state and local preparedness. The HHS figure also includes $3.1 billion to pay for new medical supplies, such as masks at the Strategic National Stockpile and research into vaccines and therapeutics. Glad to hear that, but keep in mind, masks are more of a preventative measure, which where they get these mostly online, we're probably going to be knee-deep in the epidemic. They need to be looking at curative treatments as well, putting certain medical capacities online. And even if they don't know precisely what medicines are going to be producing, I mean, the nature of large-scale industrial production is such that they need to be laying down infrastructure now. I don't see anything in this for that, whether that's done by private-public partnership or through direct public intervention. I don't really care. Probably a blend of both would be a good idea. Nonetheless, that needs to be happening. Okay, so the funding agreement comes as fears are rising of coronavirus spreading in the United States, with reports of more than 80 related infections across the country. And that number is too low. We'll give you an update as of right now, which is, let's see, we're at 8:21 a.m. This update's from 8:20. And the U.S. as of this moment is reporting 233, so that continues to go. And, by the way, we have now officially passed 100,000 cases. We're at 100,249 cases. So there you go. We are now in the six figures worldwide, according to Johns Hopkins, World Health Organization, and those entities. So we'll skip about these numbers because we're higher now. The American people are counting on our government for a fully funded, coordinated, and comprehensive government-wide response to the coronavirus, said Rep. Nita Lowey, New York. Actually, I don't want to say the parties, doesn't matter. Who cares? The House Appropriations Committee said in a statement. The House Democrats' emergency supplemental consists of robust, entirely new funding and strong transparency and accountability measures to fully address the virus and keep Americans safe from this growing public health emergency. We must enact this legislation because lives are at stake. The panel outlined stress that the plan includes $950 million for state and local agencies to track the illness among infected patients, laboratory testing, and mitigation. And hopefully, if they need more, man, they'll just keep opening it up. I mean, this is why you save money for a rainy day. The rain is coming, right? It's time to do that. And America's a wealthy country. There's no excuse for us not devoting our full effort to this in the war that this is. It also noted the measure includes $435 million to support health systems overseas to prevent, prepare, and respond to the coronavirus, plus $300 million to respond to humanitarian needs. It provides an estimated $7 billion in low-interest loans to affected small businesses. That's something we saw in South Korea and other countries, that there's going to be, and say you're a small restaurant in Seattle, right, who employs people, you're done for a little while, and we're going to have to figure out ways to go through there. Debt forgiveness is going to have to be a part of this. I know that's not something we do in America. Maybe it's something we need to look at. I think it's important. Okay, so the measure also includes a provision that was a high priority amongst Democrats, ensuring the funds can only be used to address the coronavirus and other infectious diseases. Democrat leaders raised concerns that the Trump administration would use the funds for other purposes. I think that other purposes here is okay if it's coronavirus related, like building basic public infrastructure to deal with food scarcity, and which is going to become a much bigger problem. Logistical breakdowns and the ability to create medical supplies, I think, is something, and maybe this wasn't the right time for that, but that conversation needs to be ongoing, and the Senate needs to put everything to the side for the time being. And look, I know it's election season, I know people are fighting on that, even that stuff needs to be pushed to the side for a little bit, and whatever we have to do, let's just focus on this. I'm not saying don't have an election, I'm just saying that you want to focus on this, because you don't want people getting sick. Senate Majority Leader Mitch McConnell, Kentucky, or do it remotely, whatever you have to do, on Wednesday lauded the bipartisan efforts to reach the deal. The way to secure these urgently needed resources with speed and certainty was forego partisan posturing, forego micromanagement at the leadership level, and let bipartisan appropriators do their work, McConnell said shortly before the details were announced. And so I'm going to share also, this is from Congress.gov. I have the bill that was there. Obviously, when it goes to, just for those who don't know how Congress works, the House and Senate both pass a bill. They reconcile them if there are differences. It gets sent to the president. He signs it. Okay, no one's going to veto this. So it just goes into a lot of detail about what goes to. Here's my concern, broadly speaking. And it's not, at this point, something that is a question of what has been passed by the Congress, but more about how the Secretary of Health and Human Services and the Trump administration does this. There will be a temptation, as there has often been in these situations, to put a lot of money toward the vaccine research. Obviously, that's an important piece of this. Do not let that happen at the neglect of the ability to manage this, that we're going to be fighting in the best case scenario to, again, something where we probably will not see the creation of a vaccine for this. In fact, I will add some evidence to that for at least a year. And given that this is an RNA replicating virus that has already shown the tendency to mutate, we have to at least consider the possibility that the solution to this may not exist in a vaccine. So I would be incredibly skeptical that we're going to see something emerge very quickly, but we're going to add a piece in here. This is from the independent.co.uk, just a quick update. And it's by Michelle Cortez from 4 hours ago. Coronavirus. Vaccines for disease won't be ready until next year, drug makers predict. Developed treatments need to outpace the evolution of COVID-19, making a permanent and worldwide medicine a daunting challenge. I think that's a very realistic estimate. Drug makers are racing to find treatments and vaccines for the new coronavirus, but crossing the finish line would mean bucking a long and discouraging history, and it may not pay off. The pharmaceutical industry says it's up to the task of getting therapies to market quickly. And look, I don't want to say this in a negative way, but let's be honest here. When the government's throwing out billions of dollars, corporations are known for going to grab their share of it. There's going to be a lot of promises made, and in the best case scenario, a lot of them are not going to work. In fact, most of them will not work, and we'll be very lucky if one of them works. And even if one of them works, I don't think we can assume it'll work forever. So this article gets to that. At a White House meeting with President Donald Trump this week, executives from some of the world's biggest drug companies said they were making progress. Antiviral medicines could be available in months, they said, with a vaccine by next year. Get it done, Mr. Trump said. We need it. The history isn't encouraging. Over the past 2 decades, 2 other deadly coronaviruses have leaped from animals to humans. An Ebola outbreak killed more than half of those it infected, and a wave of Zika infections harmed babies before they were even born. Pharmaceutical companies spent billions trying to protect the most vulnerable from those pathogens, but were left with little to show for their efforts. There's no guarantee coronavirus will be different, but scientists worldwide have been moving fast. Researchers in China quickly provided its genetic sequence, giving other scientists a faster start in the hunt for treatments and vaccines. More than 200 clinical trials in China are testing everything from drugs first developed for HIV, and the flu, and that's your remdesivir sort of stuff, to antibody-containing flat plasma from recovered patients. There are more than 90,000 people infected and 3,000 dead worldwide from the virus, which broke onto the world stage less than 3 months ago. So in the time she wrote this article, the number's gone up 10,000. That shows you how fast it's moving. And that's going to continue. It's going to accelerate. Don't be freaked out. Don't let odometer effect blind you to the challenges in front of us. We have to focus on little chunks we can handle. Alongside the puzzle in the laboratory exists another problem: translating the effort into treatments that can quell the outbreak and yield a return on the company's investments. Stocks of drug makers and biotech companies have racked up big gains on the hope that industry will see a windfall from treating COVID-19, the disease caused by the virus. And I hate to say it here, but so much of this gets caught up in economics, and really we need to get past that. Not that we shouldn't invest in our most talented people, but and corporations as well. I'm not trying to take shots at just business for the sake of it, but the money part of this is, let's make sure we keep that in the right balance. Moderna Inc., maker of the lead vaccine candidate and one of the most notable winners in that rally, has surged 50% in just a few weeks. Gilead Sciences has seen its market value swell by $17 billion since the outbreak began, on hopes its antiviral drug will be a viable treatment. Those bets are being placed despite caution flags from history. One Ebola vaccine that took years to develop isn't expected to turn a profit. Another heralded Ebola drug, MAP Biopharmaceuticals' ZMAP, has not made it out of the lab. A test and vaccine for Zika found few takers. In 2009, vaccines for the swine flu were developed at breakneck speed, but not fast enough. That outbreak quickly waned, and countries that had placed large orders with drug makers like GlaxoSmithKline broke their contracts. Getting breakthrough medications ready to be taken by people isn't going to be cheap or easy, but U.S. government officials say things will be different this time. The U.S. government's Biomedical Advanced Research and Development Authority, BARDA, used existing contracts to quickly fund some work. We are off to the races, said BARDA Director Rick Bright, who is leading the U.S. government's collaboration with industry to develop treatments. Something we'll have to keep an eye on, this BARDA thing, what they're doing. A lot of times you can see on these websites, they put out, they're called RFQs, requests for quotations, where they're looking for these ideas or queries, sometimes depends how you use it, where they're looking for different things, solutions, and they're looking to fund things. So it'll give us a good chance to keep an eye on what big work is out there. But right now, they said he expects it'll cost $1 billion to develop a vaccine and another $1 billion for treatment. That doesn't cover all the costs of companies working on the therapies or manufacturing expenses. So he's basically projecting that it's going to take $2 billion to find this, essentially. I want to ensure that with the funding I have, the government will be able to partner with them all the way to the finish line at this time, Dr. Bright said. Merck & Company isn't the only major company that still has a vaccine for a novel pathogen. The Ebola immunization Ervebo that won approval last year. It isn't working on a vaccine for novel coronavirus, and its leadership has a warning for those who are. If the virus is as bad as some public officials fear, everyone will need to be immunized. But not everyone gets seriously ill, so a vaccine, which would have to be given to healthy people, would have to be very safe. Ensuring that is a long process. I am very cautious on overpromising on the success of a coronavirus vaccine as well as the timing, said Julie Gerberding, who was director of the Centers of CDC during the SARS outbreak and who is now Merck & Company's chief patent officer. We have never made a vaccine for the world. And I think this is important to recognize. Vaccines do have risks and challenges, and this is a highly contentious area. I have tried to avoid going into it. I get a lot of email asking, why don't you talk about vaccines and their risks and their dangers? And what I would say is that vaccines are not a panacea, and in the best case scenario, there are problems. In the worst case scenario, there are people who get sick, and then one of the problems that makes this complicated, just for those who aren't aware of the issues surrounding this and why people have issues with vaccines, is that the government has basically issued blanket immunity to vaccine manufacturers, and there are a number of patients, parents especially, whose children have gotten sick, and that there is evidence in at least some cases that these issues have had debilitating impacts over the course of life. Why these happen is not something that really gets researched because there's no money in it and there's a lot of money going around it. And I think it's a fair thing to say that big pharmaceutical companies have a very large role. Watch any news channel, right? It's a perfect example. You'll see a million ads for different things. The media doesn't call them out because they spend a lot of money on those commercials. You know, the one where you see all the happy people in the background having a good time and hear about all the different ways they're going to kill you right before the commercial comes out, about the malpractice suits, about the big drug from 10 years ago. Yeah, that. So you end up with those sorts of situations where you have these things that are being mandated upon people, and that realistically it's taking choice away from parents, from patients, from doctors, based in fear rather than having the deepest understanding of the consequences of this because of the issue of who has money and the relationship between big business and big government. And I'm only going into the politics of this. I don't like to go into politics on this show. I try very hard not to, save as it's relevant. But it is relevant here because big business wants a lot of money to go ahead and fund vaccines. Big government wants to spend a lot of money. They want to look like they're doing something. The question we must ask is this effective? Is it safe? Is it something that's going to be good? And I will tell you, just as a matter of fact, that there are tens of millions of Americans under any circumstances, for a lot of reasons, some more valid than others, who will be skeptical about taking this vaccine, and the public policy consequences of that are something that will have to be deeply considered as we go forward. You can say you're going to force them to do it. The state of Maine recently made that decision, but I will tell you, as someone who is keenly familiar with those issues, that is only going to lead to a hostile response, and the idea that you're going to compel people to do things is a problem that will be a recurring theme as we work through this, and it's something we're going to have to talk about, and I will try to do it gently and with the hope that open dialogue between all sides and the greatest amount of transparency will provide for the best solution. So that was a mouthful, right? It's hard for me to talk like a politician, man, and just put things every neutrally. You spend time in your life, you get used as a private citizen to saying things the way you're used to saying them, and I'm trying very hard, and I hope, and I know it's appreciated, that I'm trying to do things as neutrally as possible to spread understanding rather than just advocate for one point, because the truth is there's a lot of validity on different points, and we are going to have to reconcile different and competing values at a very quick pace, and I would submit to everyone that we put health as the highest priority, and if that means we have to agree and be willing to consider things we might not under other circumstances, I think public health might mandate that. But we'll talk about it as it goes forward, and the details matter a lot. As if the current, back to the Independent article, at the current pace we're pursuing a vaccine, it will take about a year to know if the process works, said Anthony Fauci, director of the National Institute for Allergy and Infectious Diseases. In about 6 months, if the virus is still spreading widely and early results appear promising, Dr. Fauci said he'll start asking drug makers to proceed at risk. That means you invest hundreds and hundreds of millions of dollars to scale up on something you might work without definitive proof, Dr. Fauci said. If we start to see sustained transmission from person to person, we are going to be pushing everyone to proceed at risk. I think we're already there. That could be harder for some companies than others. Moderna, which has the lead vaccine, doesn't have enough manufacturing capacity to supply the shot on its own. Glaxo, which worked on swine flu, has plenty of manufacturing knowledge, but it isn't working on a vaccine for coronavirus. Instead, it's offering its drug adjuvant, is essentially a booster that can make an immunization more potent to collaborators. We are going to have to employ a much larger pharmaceutical company that's willing to do the opportunity costs that they are going to lose to get it. Dr. Fauci said it's going to be a challenge to get a major company to do that. And this is, like I said, once again, it always goes back to money, and they need to, even if the government has to compel, during World War II, the government went to Ford, went to GM, to Chrysler, the big manufacturers, and said, you're going to start building tanks, and they appropriated those factories. I know that would cause a major storm in the United States, but this is a war, and we are in a wartime footing. If we have to do that and appropriate, and have people, and I wish I had faith in the CDC, right? Because if I did, I'd say they could sit in on it, but who knows what they would come up with. These are the sort of things that, a serious country like Singapore or South Korea is looking at. Okay, drug makers and public health officials hope they can jumpstart the discovery of coronavirus medicines by exploring therapies they already sell or have been developing for other uses. Gilead's, let's see, did I? 1 second. No, okay. So it looks like the article repeated itself. Weird. But it didn't. Okay. So Gilead Sciences antiviral treatment remdesivir is in the lead in that department with several studies underway in China, the U.S., and elsewhere. Other drugs, including Abivig's HIV medicines, lopinavir and ritonavir, are also being tried, but experience suggests the first medicines out of the gate may not make the grade. ZMapp, an experimental drug created during a frenzy during the 2014 Ebola outbreak, is a case in point. The drug came to be considered the standard of care after a small study suggested it may reduce death rates. It was soon in such demand that doctors ran out of it. Amgen Inc., the Bill and Melinda Gates Foundation, and others looked into new techniques to ramp up the complex drug's mass production. 5 years later, the study results showed ZMapp did not offer the protection researchers were hoping for, and 49% of patients who were given it died. Yeah, that's the sort of solutions you don't want. And that's going to be a real problem with this sort of a coronavirus, honestly. There's not a big, good track record on this, and I think we got to be so realistic about this. And I don't think the media is being, I don't think the government's being, because everyone wants a solution so much that they're not admitting the reality, which is that it may not be that simple. And I hope I'm wrong. But 53% of the people given Gilead's drug in the Ebola study died. And to be fair, we're not blaming the drug for all of that. It could, these diseases had a 40-45% death rate anyway. So this was a real problem, but it's just saying it didn't help. Drugs almost always come with side effects, which can create serious problems for people already in distress. A study of the first 18 hospitalized patients with COVID-19 in Singapore found 5 of those who needed oxygen also got AbbVie's HIV medicine. 3 of the 5 improved, while 2 continued to worsen. Only 1 was able to handle the side effects, according to a study in the Journal of the American Medical Association. The need is so great, however, that doctors will often try anything to help their patients. I know from talking to my colleagues in Asia, when they get these severe cases, they are throwing everything at them, said Greg Poland, director of the Vaccine Research Group at the Mayo Clinic in Rochester, Minnesota. They are willing to tolerate an awful lot of possible side effects because without it, the possibility that their patients will die is so high that they are worth it. Other approaches are also being studied. Regeneron Pharmaceuticals Inc. is testing its existing treatments and also building antibodies tailored specifically to the novel coronavirus, although those are expected to take longer to develop. The most significant obstacles to getting viable therapies to market are likely to be the timing and global extent of infection. In case of SARS, the virus spread fast for 9 months, it then burned itself out thanks in part to aggressive efforts to stop its transmission. And I think in this case, aggressive efforts have failed. We've seen this spread, and that we now, because of the nature of this disease, I think have to at least admit the possibility, as the Australian study did, as well as Niall Ferguson, who was the epidemiologist that was being interviewed by the UK, that this is going to be an endemic seasonal event. And it may be perpetual, I don't know. But I think that difference kind of should impress the importance of what we're doing here. Okay, so one of the problems with making therapeutics for humans is that once you get to trials, you need to have humans who have been exposed to test them. And said Matt Freeman, who runs one of the preeminent labs focused on the coronavirus in the U.S. at the University of Maryland School of Medicine. Ultimately, you have to have the time to develop therapeutic and number of people tested in. The potential path for industry is clear. Roche Holdings AG Tamiflu brought in almost $3 billion in 2009 when swine flu was raging. Even though it's far from a cure, it hastens recovery by about a day or 2, and that may help those at highest risk avoid getting seriously ill. Most years it generates less than $1 billion in sales. Researchers are feeling the pressure as the outbreak swells, realizing the importance of their role as the urgent needs of patients with no options clash with the often slow and stepwise pace of science. There is no shortcut, there's just biology, said Dr. Freeman. Every virus has its own little Achilles heel. We think we have good ideas about how to target those things. We know what we are doing, and we are doing it as fast as they can. Think of this as like developing the A-bomb, right? You gotta survive the war while you're doing it. It took them 4 years to do that during World War II. This might take a long length of time, and I'm not saying it's going to take that long, but I think there will be setbacks along the way, and we hope for optimism, but we plan for pragmatism. If the virus outpaces efforts to contain it once again, as its cousins in SARS and MERS did, Dr. Bright said the world needs to stick with it this time. If this virus goes away, this is the 3rd coronavirus we've seen in less than 20 years, Dr. Bright said. I'm sure we'll see another one. We should finish the job. We should. And I wanted to go back. They mentioned Regeneron's Pharmaceuticals' idea of treatments with building antibodies. I honestly think that's going to prove the intermediate approach. And the reason why I say that is because some of the other things we've talked about, the antibody-dependent enhancement, the suppression of the immune system, and the question of reinfection, the difficulty of vaccines, the dangers that are unknown that we're going to see in the track record of failure, giving people the ability to bolster their immune systems, it seems to be the thing we can do that can help in the short term in the time we need. I don't know how fast they'll get it up, but the blood plasma treatments are essentially a biological version of the same principle, and they've had some curative effect in China. So what I'm thinking is that the antibodies coming in will be helpful, as well as, things you can do to fortify your immune system. For those who don't understand, how coronavirus gets fought by your body, as a very quick review, there's basically two levels. There's interferons, which go and find sick cells that have been hijacked and kill them. And then there's the antibodies that go forward and they go ahead and they try to identify, bond with the viruses and prevent them from infecting healthy cells. And what we have is this problem of not having antibodies because this is a new thing. Our bodies aren't used to this, and then we're having to develop them as it goes as part of the destruction process of these viruses. These are the sort of things that we're going to be dealing with in the short term. What can you do to make this better? You can first isolate, right? Quarantine, keep yourself away from getting sick, but you can improve the quality and health of your immune system. I know some people are a lot of vitamin C, vitamin D, those are good choices. I know a number of people are using zinc lozenges that has a somewhat of an observed antiviral effect as something you can just, use like a cough drop. Some people are very fond on that. Mike Adams, the health ranger. I will let other people defend the science and behind it. But, there are three elements that are known to have antiviral properties in terms of how they interact, and they're used for surfaces in antiviral environments. There's a study out there, although I don't have it in front of me right now, that the National Institutes of Health did that looked at three main elements, those being copper, zinc, and silver. So we'll see what comes out of that, but just something to keep an eye on, especially for those of you who are looking for alternative solutions. I'm not here to tell you what is not real. I think the problem with alternative solutions is often there's not testing that happens, and it's kind of like a chicken and an egg thing, that the big pharmaceuticals don't want to test those solutions, but conversely, that the people who suggest those solutions don't submit them for testing. I think the middle path that's sane is let's look at everything, and if something works, hey, I'd love to be pleasantly surprised and find a solution that's cheap, affordable, and can be easily deployed. Wouldn't we all? All right, so on to the next article. Let's see, we're up on 1 hour, 16 minutes. You're listening to Coronavirus Central. Good morning. Welcome to the new world. I am your host, Tom Kaczynski. We will continue on to just one case study here I want to share with you, or not case study, news. This is from CBC News out of Canada. Bethany Lindsay posted this at, looks like it was updated 6 hours ago, so that would have been about 1 a.m., well, it's on the West Coast, so it would have been 10 p.m. West Coast time, Pacific time zone. 8 more cases of COVID-19 virus identified in British Columbia, including one of unknown origin. And I'm including this because we have a lot of listeners in Canada, so I want to say welcome to you all who are listening up there in the north. And also because I think that the clusters in Seattle and Vancouver may in time prove to be linked, and that what happens in one place will probably have a lot of implications between, especially as there may be means by which this is being spread, and for the policy implications. As much as in America we talk about our southern border, the reality is the northern border is probably going to be a point of emphasis here sooner rather than later. Especially given, to be honest with you, Canada's lax position about travel bans has been concerning, and it's been even worse in the United States. Now, that's a criticism we could extend worldwide, but the emphasis on certain social stigmas over keeping the public health is going to have a very large consequence before this all bears out. And I would recommend that we abandon those niceties for the time being in suggestion that we are all victims, we are all carriers, we are all threats, and that we all need to be worried about this, and that people need to get over, hurt feelings and focus upon the challenges at hand of all people. I have done it myself. We can all do it. All right? So, British Columbia has identified 8 more presumptive cases of the novel coronavirus, including one with a woman who has no recent travel history, so that's your community spread. This is BC's first apparent case of COVID-19 spreading in the community. The woman, who is in the 50s and lives in the Fraser Health region, has not had contact with other coronavirus patients or people returning from other disease hotspots. She tested positive for COVID after visiting her doctor with what she assumed was influenza. It's another thing we keep seeing over and over again. Provincial Health Officer Dr. Bonnie Henry said officials have launched a detailed investigation into how the patient was infected, a process as she described as disease detective work. And they just have a bunch of advice in here, so we'll put that story up there. I'm not going into deep detail about Seattle today. I'm aware that things continue to spread up there. We've seen closures. I also want to say that one thing that scares the hell out of me is they are scheduled to have a big Comic-Con this weekend. For those who don't know, it's a comic book convention. A bunch of people get dressed up. They're expecting, or they were expecting, tens of thousands of people to attend this potentially. It's a very big tourism event. And the people who organize this, at least as of right now, have been treating this virus as, probably in concordance with public admission, that they are thinking this isn't so big a deal that they need to cancel it. The economic factors in Seattle, there's some people arguing for this, and as we saw with the church in Shincheonji in South Korea, or the Holy Shrine in Guam, if this really explodes hugely next week in Seattle, even more than what we know, if you have just a couple people who are unwittingly sick go to that conference, everyone's interacting and doing that, this is going to be a big problem, and this is going to be an ongoing issue that, what can we do? We've seen Switzerland, we've seen Italy, we've seen Japan, we've seen a lot of countries ban large public gatherings. I think the time is there, and if Governor Inslee's listening, or someone in his office, ban it, take the permit away, shut the site down, do what you have to do for now. I know that's a big thing. People will be mad. Don't